Well, good morning, everyone. I'm Dr. Laura Leacher, and welcome to today's Medical Grand Rounds. As usual, we'll get started with some reminders, some logistics, and then introductions for today's speaker. Please be sure to join us next week. We will be learning about checkpoint inhibitors given jointly by Drs. Eric Rowland and Molly Thomas from OHSU. Grand Rounds is a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are often here live in the room at St. Vincent Southern Auditorium on Tuesday mornings at 8 a.m. And we are occasionally live at noon on Tuesdays at Providence Portland. You can always join us on Teams Live Virtual, and you can earn CME credit by being here in the room, by watching live streamed, or by watching a recording of the event. If you check your Grand Rounds invite each week, it will let you know where we're meeting, and it also has the link to watch the video. I'll be monitoring the Q&A throughout today's session. For those of you joining us online, please go ahead and post any comments or any questions, and I'll mostly hold those until the end to ask our speakers time permits. And now to introduce today's very special speaker. We have Dr. Adriana Morse, who is the current chief resident for our very own Providence St. Vincent Internal Medicine residency. She completed her medical education at the University of Missouri, Kansas City through their innovative 6-year joint program in BA and MD. She then completed her internal medicine residency here at Providence St. Vincent. During her medical school journey, Dr. Morse became acutely aware of the impacts of burnout affecting herself and her colleagues, particularly linked to challenging experiences in patient care. This awareness intensified throughout her residency, especially during the demanding times of the COVID pandemic. As chief resident, Dr. Morse has placed resident wellness at the forefront of her agenda, pioneering initiatives to support her peers. Among those, she developed a workshop titled Resident-Led Debriefing, which aimed at empowering senior residents to facilitate conversations that help teams effectively navigate stressful events. We are so delighted that Dr. Morse will be joining our faculty in hospital medicine here at St. Vincent following her chief resident year, and so delighted to learn from her this morning. Thank you.
Good morning. Hi, everybody. I'm super excited to be here this morning to discuss a topic that I have a lot of passion for. I wanted to start off by saying how grateful I am to be here just in general. I'm super fortunate to have matched into this program, which has shaped me into the physician I am today, and lucky enough to stay on as chief resident to work to improve our training environment here at St. Vincent. I hope that I made some meaningful differences during my time here. This is like sentimental for me because this is my last week as a solo chief before my successor joins me to learn the ropes. So hopefully I'm able to impart a little bit of wisdom before I go. And I'm super excited about my topic today. I'm giving my presentation entitled Debriefing, a Tool for Reducing Burnout. So I want to clarify that I have no financial disclosures or conflicts of interest to declare in relation to this topic. I don't possess any formal training in this specific area of debriefing, but my extensive experience in addressing burnout and my commitment to enhancing physician wellness have informed my perspective on this topic. Throughout my professional journey, I have devoted significant effort to understanding and mitigating the challenges faced by healthcare professionals, driven by a passion for fostering healthier work environments and improving overall well-being in the medical community, including our very own. My objectives for this talk are to briefly analyze the impacts of provider burnout, define debriefing and its role in healthcare, evaluate potential barriers to debriefing and strategies to overcome them, and then identify some key components of effective debriefing to leave you all with a little bit of knowledge that hopefully you can use in your future. I wanted to start off with a case first, as always. This is a very personal case to me that I experienced when I was in my 3rd year of medical school. And like Dr. Leacher mentioned, I was in a 6-year program. So during my 3rd year of medical school, I was actually 20 years old. So this was a very kind of informative time for me during my journey learning about medicine and then experiencing patient care for the first time. I was a part of this case. It was my first inpatient internal medicine rotation while in medical school, and one of the very first bad patient outcomes that I experienced, and it definitely shaped the way that I view and manage the aftermath of these adverse events today. So this was a 68-year-old Spanish-speaking man with a history of intellectual and developmental disability, hypertension, type 2 diabetes, heart failure with preserved ejection fraction, and chronic kidney disease stage 4, who presented for altered mental status. He was found to have a BUN of 120 and a creatinine of 4.5 from his normal baseline of 2.3, as well as mild hypoxia with an oxygen saturation of 88% on room air. He was admitted for management of acute on chronic renal failure complicated by uremic encephalopathy and acute hypoxic respiratory failure. During his course, aggressive IV diuresis was attempted to manage his volume status with no improvement in either renal function or hypoxia. At this point, nephrology was consulted, who recommended starting hemodialysis. In the past, the patient had expressed a decision that he did not want to start dialysis in more of a non-urgent setting, like office visits, as when he was expressing those preferences. There was concern for decision-making capacity in this situation, given his underlying intellectual disability, the language barrier, as well as his worsening uremic encephalopathy. The decision was ultimately made to start hemodialysis after further discussion with his family. He was transferred to the ICU and completed the initial 3 days of hemodialysis. His mental status improved following this, and he began to express a very strong desire to stop hemodialysis. So the decision was made to stop hemodialysis despite his family kind of arguing to continue due to his ongoing distress and discomfort while he was receiving hemodialysis. He was transitioned to comfort care and passed in the hospital. And the reason I share this is my experience during this. There were a couple of things that I learned. I experienced kind of some concern that both the language barrier and the intellectual disability were contributing to his initial decision to pursue dialysis. In my kind of young mind, I thought he just didn't understand what dialysis was going to do for him, that it was a treatment he needed to save his life. But I kind of quickly felt like we were actually forcing him to undergo an invasive procedure against his will, and that changed my perspective drastically on him maybe just not understanding what it was. I felt like he did not have a peaceful passing because he was kind of subjective to doing some invasive procedures before he was ultimately transitioned to comfort care. What was the most kind of formative thing for me during this was I learned that he passed kind of in the middle of bedside rounds, and I felt like we were not able to stop and take a moment. I was forced to continue rounding and present my other patients. And then when I did step away for a moment to kind of gather my thoughts and feelings, I felt like there was disapproval from this. From my attending and fellow medical students and residents. And ultimately, there was no kind of support or debrief provided about the event, despite kind of some ongoing struggles that I was having. And so I just want to take a moment to pause there to allow us all to have some reflection. I'm wondering if people in the audience have experienced something similar, or at least remember their first bad patient outcome and how this impacted your view on becoming a physician. You don't need to share this, but just take a moment of reflection. So this leads me to my main topic of today, which is burnout. So I know the notion of burnout, kind of compassion fatigue, wellness, and healthcare have been really hot button topics over the last several years. I don't want to spend a ton of time going over this because I think we hear about it a lot and are generally familiar with it, but I do want to spend the next few minutes discussing its impacts as a means of explaining why I think the search for tools to reduce burnout and promote resiliency within our profession is very critical. So just the basic definition of burnout is a syndrome characterized by emotional exhaustion, depersonalization, and decreased sense of personal accomplishment caused by prolonged or excessive stress. Kind of to further divulge like what this means and what the symptoms are. In terms of emotional exhaustion, this can present as feeling drained, depleted, unable to cope. For depersonalization, this is the development of cynicism, detachment, or a negative outlook towards one's work. And then feeling kind of reduced efficacy, feeling ineffective, like a failure or a lack of accomplishment from your work. And this is important because this is a very common phenomenon between residents and attending physicians alike. There's survey data from the American Medical Association in 2024, which showed that 48.2% of physicians reported experiencing at least one symptom of burnout. While the burnout rates have shown some improvement since the peak of the pandemic in 2021, when I started as an intern, they remain notably high. And these statistics reflect a critical need for targeted interventions to address burnout in high-risk groups such as physicians, nurses, and those with caregiving responsibilities. And addressing workload and improving work environments are essential strategies to mitigate this ongoing issue, which I will talk about a little further. Wanted to talk a little bit about why burnout happens. This is a very multifactorial and incredibly complex issue. There are different ways that we can split into thinking about this, and I wanted to split it into kind of organizational and individual factors to give us some perspective. So for organizational factors, we can consider increased workload. These days, clinicians are expected to deal with high patient volumes, long work hours, which have been consistently associated with increasing rates of burnout. The administrative burden, such as inefficiencies in the electronic health record, high levels of documentation required, and other bureaucratic tasks detract from patient care time and also contribute to burnout. Work-life balance is something that's hard for us as clinicians to maintain. Often having to stay late after work to complete documentation is a major factor in kind of the feelings of developing burnout. Lack of autonomy and support. So oftentimes we can feel like there are limited job autonomy and perceived lack of support from leadership, which of course can exacerbate burnout. And then something I think is really important and a big piece of my presentation today is just hospital culture and team dynamics. So having negative team dynamics and a lack of respect among team members, as well as non-supportive hospital culture, are significant contributors to burnout. And then looking at a few individual factors, we have underlying mental health issues such as anxiety, depression are closely linked to the development of burnout. Some demographic characteristics such as younger age and female gender are associated with higher rates. And then professional dissonance, so feeling that there's a discrepancy between personal values and the realities of clinical practice, which can lead to feelings of demoralization and burnout. So these are some things that we experience day to day in our work that can push us towards feeling the symptoms of burnout. And I think it's important to review the impacts. So working conditions have a well-known impact, either positive or negative, on employees' health. I reviewed a systematic review of prospective studies published in 2017, which evaluated physical, emotional, and professional consequences of career burnout. So in terms of physical, burnout is associated with various physical health issues, including hypercholesterolemia, type 2 diabetes, coronary heart disease, musculoskeletal pain, prolonged fatigue, headaches, GI issues, respiratory problems, and increased mortality below the age of 45. These conditions highlight the severe impact of chronic stress on the physical health of healthcare providers. When looking at emotional impact, burnout can lead to insomnia, depressive symptoms, increased use of psychotropic and antidepressant medications, as well as hospitalization for mental disorders. The emotional toll of burnout is profound, which often results in significant psychological distress and reduced mental well-being, which we all are aware of. And then finally, the professional consequences. Burnout can lead to job dissatisfaction, absenteeism and increased turnover in tension. It also negatively impacts career engagement with higher rates of career choice regret and reduced productivity. It's also linked to decreased quality of patient care, including increased patient safety incidences, low professionalism, and reduced patient satisfaction. And obviously, these professional consequences in the medical field not only affect the individual healthcare provider, but also compromise the overall quality and safety of healthcare delivery. I think it's important to also mention kind of the impact on health equity in the realm of burnout. And so I found an article titled Association of Racial Bias with Burnout Among Resident Physicians, which was published in 2019 in JAMA, with the aim of answering the following question: are symptoms of burnout associated with residents' implicit or subconscious and explicit or conscious biases towards Black patients? So again, to review, burnout's a negative emotional state that may increase the expression of prejudices, which are associated with racial disparities in healthcare, as we all know. In this cohort study of nearly 4,000 second-year residents who self-identified as non-Black, symptoms of burnout were associated with greater explicit and implicit racial bias. Given the high prevalence of burnout among healthcare professionals, like I mentioned earlier, nearly 50%, as well as the negative association between bias and suboptimal medical care, symptoms of burnout may be significant factors in contributing to disparities in care. So the implications for the quality of care provided to Black patients and other disadvantaged groups could be substantial when it comes to the impact of burnout on healthcare providers. We've heard also a lot about interventional strategies for burnout prior to this. Of course, we hear a lot about self-care. So you need to rest, you need to eat healthy, you need to exercise. You can partake in stress reduction techniques such as mindfulness, meditation, deep breathing. You can also learn to set boundaries by saying no and protecting your time. I never quite got to this one. You can also think about addressing root causes. So really dig down and do your root cause analysis, identify and reduce those stressors that are present in your life. And then finally, we hear a lot about also seeking support. So going to therapy, counseling, or support groups, but I will say this is not typically built into the workflow of the healthcare profession, and that's something that I would like to talk a little bit about today. So jumping a little bit more into the meat of my topic, we know that adverse events are common in the medical practice, and these are major contributors to distress and burnout. And by adverse events, I mean things like unexpected outcomes, medical errors, and of course, patient deaths. And debriefing these events has been shown to improve management of grief and lower rates of burnout. And it's also been shown that physicians are more likely to seek support from their colleagues as opposed to established services. So I'm here to empower you to help kind of provide this level of support to your colleagues. So what is clinical debriefing? This can be an interprofessional meeting that occurs after an adverse event and allows a member of the healthcare team the opportunity to review and process their experiences with the aim of affecting future practice. A clinical debrief can take place at any time following an adverse event, usually when they're done immediately after, such as after a code blue. That's called a hot debrief. Doing clinical debriefing is associated with improved psychologic outcomes for providers and can increase knowledge, confidence, and clinical skills. This is an emerging practice in various clinical contexts, but there's a lack of standardization or widespread implementation of this process. And so that made me a little curious about what's the evidence behind debriefing and how interested are young clinicians in implementing this into their daily practice, which I'll touch on. I wanted to review some of the benefits of debriefing. So using clinical debriefing can provide reassurance. It can reaffirm competence and facilitate a sense of community among the team. It can allow the team to share healthy coping strategies. You can help caregivers manage grief and maintain professional integrity. And it has been shown to be associated with reduced risk of development of burnout and improved resiliency. So this sounds great, something easy that we can do potentially, but of course there are always barriers when it comes to new practices like this. So I wanted to start off by reviewing those barriers and some strategies to mitigate them. So I think time will always be one of the biggest constraints in the healthcare profession. It doesn't seem like we have enough time to do most of the things that we want. So time constraint is obviously one of the most commonly recognized barriers. Healthcare providers often have demanding schedules, making it challenging to allocate time for these debriefing sessions. Facilitators are untrained, so effective debriefing does require skilled facilitators, and the absence of adequately trained personnel to lead these sessions can hinder their implementation and effectiveness. There are always conflicting priorities, so in high-pressure environments such as the ICU, other urgent clinical duties may take precedence over debriefing, which leads to inconsistent practice. There's lack of a standardized process. So the absence of standardized debriefing protocols can result in variability in how and when debriefings are conducted, reducing their overall effectiveness as well. In some areas, there are cultural barriers, so there might be a lack of institutional support or a culture that does not prioritize or value debriefing, which can impede the regular implementation of this practice. The emotional and cognitive load. So high emotional and cognitive demands on healthcare providers, especially after critical events, can make it difficult for them to engage in debriefing sessions immediately, which is usually when they are their most beneficial. Communication breakdowns can be barriers. So events involving critical communication breakdowns are less likely to be debriefed, as these breakdowns can create kind of confusion and inhibit discussions. And then finally, there's always the administrative burden on the back end with excessive administrative tasks and bureaucratic hurdles that can detract from the time and energy available for debriefing. So I think addressing these barriers requires structured approaches, dedicated time, and institutional commitment to fostering a supportive culture for debriefing. A few of these strategies to overcome. I think reframing the perception of time it takes to complete. I reviewed a study in which the majority of these clinical debriefs lasted 10 minutes or less. And so when you have this protocol and workflow, it's not something that needs to take a ton of time. It can have a major impact on the members of the team. Train facilitators and promote use of a standardized process. So in order for debriefing to become standard practice, efforts need to be made to train physician leaders and empower all team members to request a debrief following an adverse event, no matter kind of how small or large the event is. And then, of course, improving psychological safety. So creating an atmosphere where people feel safe discussing potential uncomfortable topics is not always possible, but it is essential in facilitating an effective debrief. Ideally, such change should be a top-down approach. So this should start with educators and leaders normalizing the request of a debrief, which creates precedent for learners to follow. So my initial quest to train and empower facilitators of the debrief occurred earlier this year, academic year, in September 2024, when I held this resident-led debriefing workshop for senior residents as part of our Residents as Teachers series, which is held annually. During this, I reviewed the benefits of debriefing, when a debrief should occur. I provided a framework, and we did some small group practice using this framework. For the residents, I chose to teach the framework Pearl, which I'll just briefly show up here. The framework I'm going to teach today is very similar. You can see that there are different kind of objectives within each phase, but typically starting with a setting of the scene, exploring initial reactions, describing the event that occurred, providing some analysis, and then summarizing the event. So PEARL stands for Promoting Excellence in Reflective Learning in Simulation. And it's a tool that combines various debriefing strategies into a structured approach that includes reaction, analysis, and summary phases. And it's designed to be flexible and adaptable to different debriefing contexts. So that's why I thought it was a really beneficial tool for the residents to know that they could use it after pretty much any clinical context. I want to review the pre-survey and post-survey results that I took on this workshop, just to give some context of why I think young clinicians find this to be an important topic, and how some minor teaching on it is really helpful. So I initially had 9 kind of responses for the pre-survey. My first question was, have you experienced at least one distressing event? Examples include an unexpected patient outcome, patient death, medical error, or other serious adverse events since starting residency, and 100% of the responses said yes. And I asked, was there any form of debriefing held after the event? 7 of the respondents did say yes, while 2 said no, showing some need there. I asked, how soon after the event did the debriefing take place? A third commented immediately after, or no, 22% immediately after, a third within 1 day, another third was other, and 1 participant said within 1 week. So a lot did, 5 of the 9 did occur kind of within the same day, or at least 1 day after. And then who initiated or led the debrief of the distressing event? 50% responded the resident, a quarter responded the attending, and the other quarter was other. And I asked, how helpful was the debrief in processing the distressing event? Most found it helpful, either very helpful or somewhat helpful, and 1 person found it neither helpful nor unhelpful, and 1 person responded other. I asked to the residents currently, how confident are you in leading a debrief following a distressing event? A majority said neutral, 7 of the 9 respondents, and then 2 were confident, and no one was extremely confident. And then finally, as part of the pre-survey, I asked, have you ever had formal training on leading a debrief? And 100% of the respondents said no. So then I held the workshop where I taught this Pearl tool to the residents. I only had 4 residents in attendance, so that's why I felt like it'd be nice to talk about it again today, since I didn't have a big reach there. But the questions in my post survey included, how important do you think debriefing is after a distressing event? And all 4 stated that they felt debriefing is extremely important. So again, kind of clarifying why I feel like this is an important topic for us all to learn about. I asked, how comfortable do you feel leading a debriefing session after a distressing event? And after the workshop, they all felt either somewhat comfortable, and 1 person felt very comfortable. I asked, how likely are you to lead a debriefing session after a distressing event? And they all felt either somewhat likely or very likely, which was reassuring to me. And then I asked, can you identify when debriefing may be necessary? And they all either strongly agreed or agreed, after kind of my workshop and the teaching I provided on when a debrief might be necessary. And then I can describe the components of a debriefing session, and again, either strongly agreed or agreed. So I would think it was nice that I was able to take some pre and post survey results from this workshop to really hone in on why I find that there is a need for this, and that our young clinicians have a want for this as well. And so today I'd like to teach about a different framework than kind of what I taught the senior residents. I reviewed a systematic review article on kind of the various debriefing tools out there, and this one had very strong evidence behind it. So I'll be reviewing the 3D model of debriefing with the hopes that this will enhance your baseline knowledge and comfort in leading debriefs. This model incorporates common phases prevalent in debriefing literature, including description of and reactions to the experience, analysis of behaviors, an application or synthesis of new knowledge into future clinical practice. This can be used to enhance learning after real or simulated events, and this model is based on adult learning theory, so very relevant to all of us. These are the key components. So it's designed to address the individual, the experience, and both the micro and macro environments. There are 3 distinct parts: the diffusing, discovering, and deepening phases. It's preceded by a pre-briefing or an introduction to the process to the group, and ends with a summary of lessons learned. So pre-briefing. Debriefing should be a conversation that you as the leader, I'm urging you to be the leader in this, you as the leader facilitating based on your context and the needs of your group. This may not be a linear process, and you may need to move around the group as the group takes you. Your role as the facilitator or leader of a debrief is to facilitate discussion, maintain decorum, keep the discussion organized, focused, and respectful, as well as to support discussion that seeks to get input and involvement from all team members present while respecting each participant's own level or desire for involvement versus just having reflective listening. So initially, it should be determined who should be involved. Not all team members should be involved in the case, in debriefing the case, and picking a location that feels safe and private is extremely important. It's important to find an environment that supports learning. Adult learners must feel that the environment is safe and focus primarily on learning before they will be able to actively reflect on and share their experiences with others. To achieve this, leaders of the debrief should clearly articulate the goals of the session, which are self-reflection and learning, not assessment. In addition, facilitators should set the expectations for the course, including ground rules for participating in the scenarios, and maintaining the confidentiality of individual performance and group discussions held during that time. So to review, the purpose of the debrief session is really important. Oops. You'll state how the learners should participate in the debrief and how the leader will facilitate. And then again, set those ground rules of respecting each other's thoughts, opinions, and emotions, and then maintaining confidentiality kind of in the highest order. So an example of how someone might introduce this style of debriefing is to kind of introduce yourself. Everyone probably already knows you, but introduce yourself as the leader, and it is not your job to evaluate the performance, but to facilitate a discussion and prompt self-reflection. You'll expect the team to do most of the talking, raise questions about what was going on, identify issues, raise questions, and volunteer your perspectives. The format of the discussion is as follows. We'll be doing a debrief in 3 parts. First, we will have the opportunity to talk about our emotions and the impact of the simulation or the scenario that we were involved in. Next, we will clarify the clinical details of the situation. And during the second part, you all will analyze your own performance and evaluate how well the management of the adverse situation worked. And the goal during this second phase is to discover your mental model that guided your behavior and then talk about that mental model, utilizing all the experience in the room. We will then connect new learning to future clinical situations and finally summarize key learning points. So that can be parsed down the more familiar with this protocol you are, but really introducing the debrief in a whole, including all of the parts, so that the team members know what to expect. In the diffusing phase, the facilitator should prompt discussion surrounding the emotional impact of the experience on the learners and the description of the event and how things unfolded. The purpose of this discussion and the impact of unleashing emotions is twofold. It is to reduce any anxiety and stress and allow the learner to engage in meaningful discussion, and to allow the facilitator to conduct a needs assessment of key points for the discussion that is about to happen. The importance of allowing the participants to describe or recap the experience is to achieve a shared understanding of the events of the experience. I just want to reiterate that I think asking about feelings has a powerful impact on the learners. Learners will have just been through a very stressful and emotional event and will need to de-stress by releasing that emotion. Learners might not be ready to learn until they discuss their feelings, and they may be too emotionally involved to think clearly or reflect objectively on their experience until this is done. And the goal is to acknowledge the feelings and clear the slate for learning. After this venting of emotions, it's important to allow participants to describe the experience so that everyone in the session has the same overall understanding of the series of events that happened and can move from understanding what happened to why it happened. This description should be a discussion of the facts or a recap of the order of events. During this time, participants may reveal gaps in knowledge regarding clinical management, and this is an opportunity for the leader to engage in clinical teaching. In the discovery phase, this is a phase of reflective observation. So the leader of this provides an objective perspective on the experience to help the learner identify strengths and opportunities for improvement, specifically related to those points of emotion identified during the diffusing stage. Both learner and facilitator must identify the mental model or decision-making process that led to the adverse event. Once the learner has shared their mental model or the team has explained their shared mental model of what happened during the event, the facilitator can then start to identify gaps and opportunities for learning. Identifying the gaps requires the leader to compare the learner's mental model with the expected or target mental model. If the learner uses an old method of treating a patient and the facilitator is looking to teach a new method, the gap is the difference in decision-making or knowledge. So this can look something like, to give an example of what this would look like, it's like, oh, Dr. Smith, I noticed that you did X in Y situation. I was curious about that action because, and then you offer kind of your own mental model of how you typically deal with that situation. Can you tell me why you did X? And so this promotes kind of an open environment for discussing why decisions were made and what mental models were being utilized, and then kind of can open it up to an area where clinical teaching can be accomplished. And again, this is all after kind of initial reactions and emotions have been addressed and reassured, which I think is one of the more important pieces of this. The third phase is deepening. So deepening is an explicit connection of the learning or the new mental model that we all share now to practice. It can be facilitated during the debriefing by prompting the learners to connect what they just learned to actual practice. And so a simple strategy is to ask individuals how they can use the new strategy or information in actual practice. An example of how you would phrase this would be, can you think of other situations where this information could be applied, to kind of round out the conversation? And then finally, the summary phase at the end of the debrief is a good place to summarize the themes that have come up during the discussion and to think about the lessons learned and what the group will take away from the experience. So identifying those key takeaways. It's important not only for the debrief to be focused and guided, but also constructive, so that the members of the group have an opportunity to synthesize the debrief in a condensed way. Just by reviewing what was learned throughout the debrief and consider if there are any further steps that need to be taken, if any. And so examples of how to kind of conclude in this portion of the debrief would be asking what's one thing that you can take away from this session to use in your practice in the future to kind of round out that conversation. So that's the 3D model of debriefing. Again, there are many different tools and standardized practices on how to debrief. None are implemented kind of widespread, and so this is just an introduction to one of them for you. I encourage you to look into other methods, including the pearls, which I think is a very similar method to doing a debrief session, and find a protocol or a method that feels right for you. I wanted to end by kind of using this debriefing method within a case to kind of hone in on how this could look in real clinical practice. So, Dr. Smith is a medical resident on the inpatient medicine team who is managing a patient with severe sepsis secondary to pneumonia. The patient was initially being managed with IV antibiotics and supplemental oxygen. During tabletop rounds, Dr. Smith enters an incorrect dose of antibiotics in the electronic medical record, which results in the patient receiving a subtherapeutic dose of antibiotics for several hours until the error was discovered by pharmacy. The patient subsequently experiences worsening respiratory distress, which requires transfer to the ICU for intubation. Dr. Smith and the entire team feel extremely distressed about this error. So immediately following the stabilization of the patient and transfer of the patient to the ICU, the leader of the team, the attending physician, Dr. Patel, gathers the team for a debrief. An introduction to the process along with ground rules are established with the team, including mutual respect for each other's perspectives as well as confidentiality within this space. Dr. Patel initiates the diffusing stage by acknowledging the distress experienced by Dr. Smith and the entire team. In this moment, he reiterates that the debrief aims to create a supportive environment where team members can freely express their immediate feelings to begin to alleviate anxiety without assigning blame. And in this moment as well, Dr. Patel reassures Dr. Smith that these situations, while unfortunate, are valuable learning opportunities. And after this atmosphere of psychological safety is established, Dr. Smith feels comfortable expressing his feelings of anxiety and shame about the error made during rounds. And then with the immediate emotional concerns addressed during the diffusing stage, the team transitions to the discovering phase. So they review the sequence of events, examining the error in the dosage entry and its contributing factors, including kind of a hectic morning and needing to put in orders during rounds. Dr. Smith shares insights about his decision-making process during the hectic shift, which prompts further discussions about workflow, systemic issues, as well as communication between departments, including pharmacy and nursing. The team was able to identify gaps in knowledge as well as process, which allowed the team to pinpoint specific areas needing improvement in this workflow. And then after kind of this discovery phase, we move into the deepening stage where we turn to focus more on long-term learning and strategy development to change future practice. So Dr. Patel, as the attending, leads a conversation using the electronic medical record, possible implementation of a more robust cross-checking system, and regular education sessions to strengthen decision-making under pressure. And then finally, the team summarizes the event and what they will take with them. So overall, this structured approach contributes to a culture of continuous improvement and resilience within clinical practice, and can be used fairly quickly, like I mentioned, in the majority of cases when clinical debriefing is done after an adverse event. Typically takes less than 10 minutes when you have kind of this workflow that you're comfortable and familiar with. So a few takeaways that I want to leave you with. Burnout is extremely common among healthcare providers and impacts lots of people that you see day to day. It can significantly impact our physical, emotional, and professional health. There is a critical need for targeted interventions to reduce burnout and improve resiliency in healthcare providers. And today I discussed clinical debriefing as a tool which has been shown to improve psychological outcomes for providers, as well as increase knowledge, confidence, and clinical skills, which hopefully will improve our patient outcomes in the long run as well. The 3D model of debriefing is one of the very many structured tools that we can use to assist ourselves in implementing debriefing after adverse events. These are some of my many references, and then I will open it up to any comments or questions.
Dr. Morris, thanks so much for sharing your experiences and some specific tools for next steps. I'll let folks gather their thoughts and comments and questions here in the room and open with one that has come through online. Do you have any thoughts about providing this sort of approach to outpatient providers or providers post-residency? Seems like there may be even less bandwidth or space for this in the outpatient setting.
Yeah, definitely agree. I chose to focus on tools that you can use in any clinical context. So I provided a case in which this happened inpatient, and it seems more likely that like an adverse event that could be immediately addressed would occur. My hope would be for this to be applicable in the outpatient context as well. I did discuss many barriers to implementing a debrief, one being time, and kind of constraints of, seeing patients every 30 minutes to an hour. There's really no time to stop and provide that debrief. I think getting in the habit of, in your clinical context, including the outpatient setting, setting aside time, whether it's at the end of the day, at the start of the next day, especially if this impacted your entire team, such as like your medical assistant, your nurse involved in the care of this patient. Setting aside and finding that time is kind of the most important thing that you can do. I do think that this would be a nice topic to talk about with providers that have been in practice for a long time. The leaders of this debriefing can be anybody. So I'm imploring young clinicians such as our residents, but I think attending physicians should also feel very comfortable being able to lead these sessions for all of their team members.
Great, thank you.
Dr. Morse, this is such an important topic and so well covered, and thank you for the scientific background that you took the time to go through. I was interested in the concept of pre-briefing, and it strikes me, I wonder if you could speak to two things. One is sort of acknowledging as a culture that these events are going to happen, and that's a little bit of a shift. So curious your thoughts there, and then curious your thoughts as we think about shifting our culture, how we might create an expectation through pre-briefing, maybe before events even happen. Curious your thoughts.
That's an excellent point that, I mentioned adverse events are very common in the medical field. I think the current statistics are adverse events are kind of like the third most common cause of patient deaths in this country. And so these are events that we can anticipate happening. We're all human, and so medical errors are going to happen to all of us. So I agree that setting that expectation, whether it's you as a senior resident with your intern on their very first day, or as an attending physician, while you're kind of setting your expectations for your time together, it's really important to talk about how these events do happen and that they are expected and that we can use them as learning opportunities, as I mentioned. I think in the pre-briefing, that is an excellent time to just put that notion out there. And it's something that you should say over and over and not kind of let fall to the wayside, that kind of adverse events are expected and that we can use them as opportunities to move forward and learn together. And I think that's part of setting the psychological safety in the very beginning, so that when you move into the diffusing phase, you can elicit those genuine emotions about what happened. Because as I mentioned, if we're not able to kind of express those emotions, we might not be able to move and learn in the discovering and deepening phase.
Thank you, Adriana. Amazing as always. Do I get any credit for recruiting you to the program? So So I hate to bring this up, but I wonder if at some point we should talk with some of our legal colleagues, because having had to sit through many Sentinel event reviews, the lawyers would always say, make sure you guys aren't talking to each other, because it is always better if you can say, no, we did not discuss this. And I always thought that was just terrible, terrible advice, because this is how we process. It's also how we get better in the future. But I just wanted to make sure, and maybe Michael knows, who sat through way more Sentinel events than I did, where our legal advisors fall in on this.
You always ask the hard questions. That's a really good question. I know that, a lot of these events that as like resident teams are not going to reach kind of that significant level, but there are events that some of our residents have been involved in that are major medical events and have had formal debriefs established with professionals. And so I assume by kind of Providence providing the time and the space and the professional to lead those debriefs, that they felt like it was the right thing to do. But these day-to-day, like mini debriefs over these small things that we experience, whether it's just a patient being upset that we're not able to provide certain cares for them, it doesn't have to be kind of like the extreme end of a major medical error that's likely to go to court for any reason. But I don't know their opinion on that. I'd be actually really interested because I've never heard that before, that it's best to, we'll hear from Dr. Goldstein maybe what he thinks.
So I don't know the true answer to this, but being involved as a department chair for a number of years, sitting on the Med Exec committee and seeing this play out, and being part of the Sentinel event in a regional level. So, one of the examples I think we can draw a line to is like M&Ms, right? Those are peer protected. I think the key there is just being intentional and making sure everyone who's around knows that this is a peer protected, situation, and you just make that clear. And that generally, I think, protects you. Oregon's got very strong, peer review laws that pretty much, if it's an understood peer-reviewed, peer-protected situation, I think you just have to be explicit as to that's what this is, and people not to be kind of misunderstanding part of the purpose, because that's what our M&Ms are, and clearly those are not, discoverable on the other side. So I think as long as we're intentional about it, I think you're in pretty safe space.
Yeah, the pre-briefing is like an essential component of this, setting expectations and kind of talking about confidentiality, and that this is a discussion that stays like in this room and is meant for our own benefit of kind of releasing the feelings that we have experienced from this event, as well as kind of learning opportunities that we can take from it and move forward. And I found that when I have not had this, in residency where things have happened in the ICU and you just move right on to the next room, versus when we take some time to sit down and be intentional and kind of talk through what happened, I come away from those experiences ruminating a lot less and being able to sleep a lot better. So that's kind of my main prerogative for this, is that we can provide some tools for improving kind of resiliency and our ability to experience these things that are inevitable.
Great, I'll take another question while we see if there are other thoughts in the room. Thanks, Dr. Morse, for acknowledging, right, we encounter a lot of difficult things all the time, and many of which may not explicitly involve error or concern for error. You outlined barriers to debriefing, and I love that you're empowering us with motivation and tools to do it. I wonder if there's opportunity sometimes to debrief that may have only one D, for example, and not wanting sort of doing it just right to be a barrier to doing it. Can you comment on are there problems we should be aware of in approaching a debrief as an amateur? Is it okay to just give it our best go? Any thoughts there?
That's a really excellent question as well. I did talk a lot about how I feel like this would be better if we kind of had a standardized approach and it would be more effective, but I don't think that that should be a barrier for us to not attempt. I think this basic framework is important to utilize, but I don't think you have to feel like you're like a professional at it by any means. I've highlighted a few of the pieces that I find to be the most important, which I think is expressing the emotions and the initial reactions, as well as kind of going through your idea of like what happened during the case, and then finding a few teaching points or learning opportunities. And it doesn't have to be much more in depth than that. And that's why a lot of these debriefs take such little time when you're intentional about sitting down and doing it. So I do not think feeling like you are not a professional facilitator should keep you from trying to do these. I don't think there is a huge way to mess this up apart from not acknowledging like feelings and trying to find some learning points to use in future practice.
Your lack of sleep comment prompted a question, and I'm wondering if debriefing requires more than one person. Is it possible to use this framework to help yourself process through an event?
That's a really good question. Like this is meant for a team setting so that you have the ability to bounce your ideas off of other people that were involved. And even my goal would be to have some facilitators of debriefing, particularly for the residents, that would be kind of outside perspectives. I think that outside perspective on a situation really provides a lot of benefit. People that are so closely entwined in what happened during this event have a hard time kind of seeing it for what it is at times. And so while I think it's good for you to try and process your own emotions and your reactions to kind of an event that you experienced, I do think having at least one other person to bounce those ideas off of would be really beneficial.
Perfect. It looks like we are coming right up on 9 o'clock. Thank you, Dr. Morse.